Welcome to this PowerPoint. This is a new one for this semester. I realized that a lot of the students in this class are in healthcare, and I wanted to do some research and some presentation about how we can connect the material in this course to the field of healthcare communication. And I decided that the best place to do it would be in the intercultural communications section. So the big idea of this is that it might be helpful to think of communication in the healthcare field as a subset of intercultural communication. I say this first of all because students and new practitioners become enculturated into a new culture when they become healthcare professionals. Think about the definition of culture. It involves values, language, ways of thinking, ways of behaving, and ways of differentiation from others. And we'll have that on the next slide. But when you learn to be a respiratory therapist or a nurse or a PA or going into those other fields, you learn new language, you learn new values, you think differently about data and about situations. You have to behave a certain way because of the patients and your colleagues. And to a certain extent, and don't get me wrong here, you become other. You are not one of us. You deal on a daily basis with pain and sometimes death, and you just become much more aware of those kinds of things that a lot of the rest of us don't. So that's what I'm talking about here. And I'm going to use a lot of personal examples. My mother was in hospice before she passed away. This was in 2014. And that was a very different experience of taking care of her and all of her needs and doing things that you don't think you'll ever do for your parents and watching her die and these kinds of things. So you become a sort of a different culture when you become a healthcare professional, but you also go back and forth. You're sort of bicultural. Also, healthcare professionals are often, almost usually, communicating with patients or clients of different cultures than their own, or patients and clients from non-majority cultures. And so that's a very important part. You're in a different culture as far as even just people of your own ethnicity, culture, or background, but you're also going to be talking with and communicating with people of different backgrounds. So, I want you to think about that for a minute and maybe jot down some ideas. How is your healthcare profession like a learned culture in your experience? You might think about what did you have to learn and unlearn to become a healthcare professional in your field. Now, that term of unlearn means it doesn't mean you forgot it, who you were or how you used to be, but you have to reorient yourself to a different way of thinking and being and behaving because of being a healthcare professional, at least in the workforce. So I want you to think about that. Maybe it's been so gradual you didn't realize it, but I've known a lot of people who went through nursing school and experienced that, for example, and there were a lot of things they had to learn and unlearn. So just a reminder, when we say culture, we mean a system of learned and shared symbols, language, values, and norms that distinguish one group of people from another. So you can see why I'm saying that becoming a health care professional does involve a different culture. And this is a learned culture. It's not genetic or geographical or racial, ethnic. And some of the behaviors are visible, such as what you might wear. A person who wears scrubs, we know that they're in the healthcare profession. I would not wear scrubs because I don't have those credentials. I'm not in that culture. And others are invisible, ways of thinking and language and even nonverbal. I sort of devised this little diagram. I like little diagrams like this, okay, just to say that effective communication skills are tied to, and probably the arrows would be better as is like ropes or something, but when we've talked a lot about in this class about what is meant by effective communication skills, and they're tied, of course, to clinical knowledge and experience. You have to know your job, you have to know the field, and that's a primary thing. But you can know that and not be an effective practitioner and communicator with your patients or your colleagues as well. Effective communication skills equally, or almost equally, are tied to empathy, emotional intelligence, or we often say EQ, mindfulness and self-awareness, which we're going to talk about a little bit more. Also tied to critical thinking. And what I'm going to use for critical thinking is, I think, the best way of thinking about it for our purposes is understanding theory and applying that theory, the application of knowledge in the right setting and in the right way. And then the breadth of and depth of language knowledge. And of course, sometimes, it helps to know foreign language. That's another issue altogether. But the larger your vocabulary is, the more you can relate to other people. And you have a repertoire of words to use with people that they might not understand, and they probably won't understand your clinical language. This is one of the biggest issues people have with healthcare professionals, is the lingo, the jargon that they get into, and every field does it. But that's a big barrier to communication with patients. And then the control of nonverbal, your voice, your face, your eye contact, physical movement, and non-intentional movements. Making sure you're looking at someone and giving them your full attention when you're dealing with them. Keeping your voice modulated, not showing any kind of emotion on your face that would be discouraging or scary for them. These kinds of things. So control of your nonverbal communication. So these are kind of just sort of a diagram to get you thinking about those different parts. So I'm going to look at two areas of focus here mostly, and that's going to be the mindfulness, empathy, self-awareness aspect. And then we're going to look at the language aspect, what I call the granularity level. Again, little diagram. This is a little bit of a variation on what I would say for public speaking, but communication needs to be intentional and purposeful. You need to have plans and scripts in your head, not habitual scripts, but go in with ideas of how you're going to say things, and we'll talk about that a little bit more later. But there's three things that come into that plan that you're going to execute, that communication plan. Self, that's you, the audience and your understanding of the audience, and the purpose you have. So in terms of self, we're going to talk about mindfulness and things along that way, and empathy. First starts with awareness of circumstances and stressors that affect you. Now, I understand the healthcare profession can be very, very stressful, and since I'm not one, I'm not going to sit in judgment of anybody, because I know it can be stressful. I have a good friend, her daughter just finished nursing school at Chat State, an associate degree, and it was very stressful on her. It controlled her for years getting into the program. She did not have a strong academic background because she was homeschooled, and that's another issue. But she worked doggone hard to get into their program and to finish it. And she'll be a great nurse because she has a lot of great qualities. But that in that stress, you have to be aware of the stress. So the self-awareness. And along with that is the ability to name what you are feeling mindfully, and sort of stepping back to reframe the feelings and situations objectively. Not in a sense of blaming, but in the sense of causes. How did I get to this place? And then look for productive ways to use it. So I'll give you an example. I got this from a book, but I thought it was a good example. Fella that's a nurse, he he comes into work. He's running a little late because there was a traffic jam, and we've all had that experience. So he's rushing into work just on time. And he makes a few offhand remarks because he's annoyed about the traffic jam, and it's overheard by patients as well as his colleagues. Things that they might not understand the context of it, but they hear it and they're put off by it. They lose trust. They don't know where he's coming from. It concerns them. So he needed to, number one, be aware of what was stressing him and think about that. Be self-aware. Step back and realize the traffic jam has put me in a bad state of mind. How can I get back to where I need to be and not bring that into the patient care? That's just one example, but we could probably think of others. And I'm sure if this were a face-to-face class, we could have a great discussion with those who are in healthcare. And of course, in order to do, understand the self and the mindfulness, you have to have self-care. And that's easy for those who are in helping and health professions to forget their own minds and bodies. Mindfulness leads to empathy. It's not the other way around. You have to be thinking, and mindfulness is a really interesting thing. It's not this yoga meditation thing necessarily. It's being aware in the moment of how your body is affecting you, how your emotions are affecting you, how the situation is affecting you, being what we call reflective in practice or reflective in action, and not just going on automatic pilot, because we all function on automatic pilot. How many of us have driven from our homes to the campus or driven from our homes to work, and when we got there we said, how did I get here? We put our driving brain in automatic pilot. I've done this so many times and it scares me. And it was, how did I get here? I don't remember getting here. I don't remember taking the turns to get here. We do that. So that's not being mindful about our driving. So we get into these automatic behaviors that that get to control us. So we have to start with the mindfulness, and then that leads to the empathy. Empathy is not sympathy. It's not just having feelings with the other person or trying to help them. Now, those are all good things. They're not bad things, but they're not empathy. And so I'd like you to stop and watch this very short video by Brene Brown. I think it's the best little thing. It's not even 3 minutes long, and it's kind of cute and clever about empathy. And she points out that it's about perspective taking, staying out of judgment, recognizing emotion in other people, and then communicating that recognition appropriately. So she has some good examples there, but that's what empathy is about. It's not about just having feelings for another person. Because I'll be honest with you, if all empathy is about is just having the same feelings another person does, then you're going to be in a lot of trouble. I could tell you a lot of stories here. I won't, but people who, there's actually research to this, that people who are empathetic in that kind of way, where they feel the same things that other people do, they're not very effective because they can't act, they can't move, they don't get things done. They're not necessarily more active, in social causes and things like that. So empathy is not just about having feelings. Now, we've talked about the self. We'll talk about the purpose. What are the self's goals? Well, obviously, it's the best outcomes for patients and empowerment of the patients for self-care as possible. When they leave the hospital or leave the unit, the clinic, they have to be able to take care of themselves. And the only way they're going to be able to be empowered is to have clarity of instructions and empathetic communication. Unfortunately, these kinds of goals meet some pretty significant barriers. The first one being time. Sometimes we feel there's always enough time, but we feel like there's not enough time in the day. We are given productivity goals by our organizations, which can be counterproductive. A big thing today is the electronic medical records, because there's a lot of research to show the doctors hate them because they have to spend so much time looking and inputting things and they're not able to really give the patient the information they need and the care and attention. It's a big problem. My own doctor is really good about giving me full attention, and still, he talks about what he's putting in there, which I think is an effective thing. That's probably why he's such a great doctor. He's rated very highly. He's able to say, "Well, let's see what we're going to do here," and he talks about what he's putting in. He lets me see it, so it's not just some magical, mystical, secretive thing that it's going into a portal somewhere. I know what's going on in my records. Um, Other barriers are gaps in patient understanding, which could be due to their background or their health or cognitive functioning. I mean, when a person's sick, their cognitive functioning is not is not always the best, as you can imagine. The presence of family. Sometimes family is great to have there. Sometimes the family is more of a problem. I can think of both situations I've seen. Obviously, cultural differences, and one that is major is fear. If you're in the hospital, you're not going la-di-da, this is great. You're scared. If even when doctor's office, you're scared. People don't go to the doctor's office because they're feeling great and happy. They go because something's wrong and they're concerned. So this the emotions of fear. Okay. So in terms of the audience then, and that brings us to that point, is what are the patients going through? Well, fear and uncertainty, confusion, pain, that's why they're there, vulnerability. Let's face it, folks, you got to take your clothes off in the doctor's office in the hospital. You're not wearing your normal clothes. And that sometimes is, we make jokes about it, but you are vulnerable when you're not in a state of dress like everybody else, and you're more in a state of undress. They could be very angry that they have to be there. They have to be maybe shameful. Now, this is a whole different thing, but there are a lot of medical conditions that are related to immoral kinds of things. Uh, an STD, for example. We assume a person with an STD, did behaviors that caused them. They had multiple partners and were not wise maybe about their partners. That's not always the case, but that's kind of a conclusion we make. A person with emphysema. Okay, you smoked. Why did you smoke? There's this, you did this to yourself kind of mentality. You wouldn't be here if you hadn't done these kinds of things that you were told you shouldn't have done. And that may seem kind of harsh, but you can't get around that. There are certain aspects of shame in certain medical conditions. And, that's just something that you have to be aware of. They're going to possibly have feelings of inferiority and being stupid or less than because they're surrounded by all these smart people who can use big words. And nobody likes that. Some people will feel inferior, and some people will just be mad and lash out because they feel like they're being pushed around by smart people. And then trust in authority or mistrust in authority. Now, some people, especially certain cultures, will have a great deal of trust in an authority that has a certain, coat on, or the scrubs, or has a position in the hospital. They've been taught in their culture to respect that. Some people have had bad experiences, and they might mistrust the authority of the doctor or the nurse and feel like they don't, those people don't have their best interest in mind. So those are some things to think about, what the patients are going through, and that's where the empathy comes in. You don't feel that, but you're aware of that, and you're taking their perspective. So this brings us to the question of language, and I like to talk about language in the sense of a granular level, that small tweaks in language can make a big difference. And I'll give you a couple of examples from teacher world, okay? I have this tendency when I'm teaching, I'm always asking students if they have questions, so that's okay, but I'll say, are there any questions, observations, hallucinations? I'll make a silly statement like that, and people will laugh, and I do answer their questions, so it's not a huge problem. But I realized that somebody pointed out that instead of saying, do you have any questions, you should say, what questions do you have? Now, that's a very small difference, but it's actually different. a big difference, because it assumes you have questions, and the students always have questions. So it's just, let's get that out of the way instead of them having to get over the barrier of, yes, I have a question. It's, okay, you have them. What is it? Okay, we've leveled the playing field, so to speak. Another one is when students will say, well, he gave me a B, or she gave me a C. No, we don't give you grades. They're not candy we pass out. You earn your grades, and we like to say that, but there's a difference. Whose responsibility is it? If I give it, it's mine. If you earn it, it's yours. So that's a small difference in wording, but a big difference in meaning. However, so much of our language is habitual, and this first one I'm going to laugh about, because I've had situations where the doctors would say, well, or the nurse would say, it's a routine procedure. And I want to say, it's routine for you, maybe. It's not routine for me. I'm going under anesthesia. I'm getting probed and everything. It's not routine for me. I've never had this before. It's routine in the big scheme of healthcare, but it's not routine for me. So even saying something like that is a little off-putting. It's a little bit, oh, you shouldn't worry about it. It's routine. Well, we all know that bad things can happen during routine procedures. It's not like bad stuff never happens. Okay, then of course there's the jargon. One of the biggest example is NPO, that nothing by mouth. And of course, nothing by mouth does not translate to NPO. It's Latin. But that's a typical term that gets thrown around in medical care that doesn't communicate. And we could go into the jargon of medical communication. A lot of times, it's not just the jargon; it's also the way the sentences are structured, and the level of the language, the very formality of the language, instead of it just being direct. And that's kind of a subject all unto itself. We'll get in a little bit more of that in a minute. The word should. Should implies moral certitude. There's only one way. And sometimes there is, but sometimes we use the word should, and it may not be the most. And as I mentioned before, that moral component of medical conditions, that you do not imply that somebody did something wrong. That it is what it is. If somebody smoked for 40 years and they have emphysema, well, you can't change the past. I often say even God can't change the past. So, it is what it is. They're going to suffer from that, maybe, the emphysema, which is a horrible disease. A lot of people don't realize, but it's, you can't change what has been. So it doesn't really do to say, you shouldn't have done that. Something I really like is Gibbs' defensive and supportive climate creation. And you can look this up, and I've just put the basics here, but you can look at this briefly. What he does is he has 6 categories, and he shows the defensive communication versus supportive communication. So you've got the defensive on the left side and the supportive on the right side. So evaluation is the opposite of description. Evaluation would be judging of others' behavior, asking like, why did you do that? Putting a value judgment on people of some sort. Description is describing their behavior, giving it context, stepping back, not putting value judgments on things. Control is imposing solutions without regard to the input or needs of others. You don't really get any input from them. You're just saying this is what you should do. Versus problem orientation, where there's a collaboration on win-win solution. Now, let me say at this point, if you're in an emergency situation and you got to get the person intubated quickly or something, okay, you're not going to worry about control versus problem orientation. This is after the crisis is passed kind of communication, where you want compliance, you want good outcomes, you want good trust with the patient. And so you're not going to get trust in the defensive column. You're going to get trust from the supportive column. That's the whole idea. Strategy is the idea of manipulation. We've all felt manipulated. So think about those times you felt manipulated and what the person did. A lot of times they will only give you one option. They won't give you another option. that's often when we go to a doctor, we feel like, well, I have to do what this doctor says, or I have to, this is my only option. And so we feel manipulated in that way. Um, the opposite of manipulation or strategy is spontaneity, which is direct, honest communication without an agenda or trying to hide something. Now, of course, you do have an agenda. You want them to have the best patient outcomes, but you're not doing it in a way that they're not aware. Just like I said, my doctor shows me what he's putting into the electronic medical records. I feel very good about that. All right, 3 more. Neutrality versus empathy. Neutrality in this case, he means indifference, okay, versus showing displays of support. Superiority, this one's really hard for people who are more educated because we subtly sometimes remind others of our higher status, role, knowledge, etc. And it's not that we don't have more knowledge or we haven't achieved certain things, but we shouldn't let that get in the way of us being equal as human beings. As human beings, we're equal. I have a better, position job-wise because of education, some of those kinds of things, but I'm not a better person. Somebody was saying today, everybody puts their pants on the same way. Nobody puts them on over their head. Okay, so we're all equal as human beings. And then certainty is my way only versus provisionalism. There are other viewpoints to be considered and discussed. So those are some ways you can think about the defensive and supportive climate. I've always found that to be a really good model. So I have 2 different statements here. That is exactly the kind of quality wound care that will help to get that incision healed up quickly. It seems you've got a good grasp of the technique. So this is a nurse talking to a patient about wounds and that patient learning to do the wound care, which is so very important. Rather than, I'm so glad that you are doing such a great job. Okay, I want you to think about those. How are those different? They're both positive, but is one more empowering to the patient and the other more about the caregiver, the caregiver's emotions, the caregiver's approval? Think back to the supportive defensive behaviors. Is one more a value judgment? You're doing a great job, okay, which is great, can be overused. Where the other one is more about objectivity, description. There's some things to think about, and I'm not saying either one is perfect or horrible. There's, I can see why, the second one is positive, but it may be sending the wrong message, that it's more about the approval of the nurse than it is about getting good outcomes. And of course, timing is everything. There's the open-ended versus closed-ended questions. There's some times when open-ended questions are what you need to try to assess what's going on, what kind of environment they'll be in, whether they can, how they'll be able to deal with their aftercare and things after hospital care and that kind of thing. And then sometimes you just need closed-ended questions. Yes, no, maybe, that kind of thing. You want to be very careful about giving the impression of hurriedness. Oh man, I'm the worst here. People are always telling me you're so busy, and I want to say, stop it. I'm not that busy, but I know that somehow I'm giving that impression, and I don't like that. And of course, sometimes a person is not ready for information. Right after surgery, a person is often ready for information. They're not going to hear it. But that's a whole other thing. I'm going to attach a document in Georgia View that you can read. It's about language in healthcare, and I found it very helpful. And I've put a few of them here. You can just kind of look at these examples of types of responses and how you could say things or express yourself that would be in positive ways. So you can look at those and just stop and look at those yourself. Okay. And then finally, intercultural communication with patients. This is a huge topic, and so I'm just going to touch on it. I think this is where Hofstede can help. I'm a big Hofstede fan. And you remember that he had the 6 categories: collectivism, power distance, masculinity, long-term orientation, uncertainty avoidance, and indulgence restraint. And these are really, really applicable in healthcare communication. Collectivism. Who makes the decisions about the patient's care? A family, an individual, even a larger clan or group, community. Um, I have some friends who are from Sudan, and I met them through teaching English, and it's just very interesting. They're a much more collectivist culture. They do everything together. So, she said, I have to do such and such because that's what we do as a culture. One of the gentlemen, he married a girl that his parents picked out, and he more or less confessed to me that he was just doing it because that's how his culture was. I don't know if he loves her. They have a child now. I hope so, but he married her because that's what he was told to do. And he's 30, early 30s, but that's life for them. Um, of course, Americans find that really strange. Maybe we are the strange ones, though. Power distance. This has to do with power hierarchies, and this would fit into attitudes toward authority. How would they see the doctor, the nurse, the healthcare giver, versus an American might not see them the same way. A typical American, I should say. Um, Masculinity. This gets into who is allowed in the room, who's allowed to touch patients. Um, in some cultures, there can, a male doctor does not touch a woman. You have to have a woman doctor. Who's allowed in the room to see the patient. Is the husband has to be there if the doctor's there, things like that. Long-term orientation, this probably relates to religion, um, as well as tradition and change. How are they going to view death? You know, um, some cultures see death as, you're going to be dead a long time, but you do have an experience in the afterlife. So, that this is a preparation for that. Uncertainty avoidance, and that's probably not as you know close and tied in, but then the indulgence restraint really is, because um, this would have to do with pain medications. How much pain medication do you want to have? um, Family sacrifice. The family's willing to make a sacrifice and not indulge themselves for the good of the family. It would have to do with other parts of their health care, how hard they are willing to work for it. I could get into some judgmental things here, but I won't. So, what I like to say about intercultural communication is that it begins with transcendence. And by that I mean you have to step back and so almost sort of get above and look down on your own cultural situation and understand that it is not the only one that exists. It is a way of being. It's not the only way. It may be the way we like it. Now, I'm not going to say that if you like your culture, you're ethnocentric, because we all like our cultures. But you do have to be able to sort of rise above it and look down, from a higher view about what's really going on. Or if you prefer stepping back, then it continues to attuning to different perspectives and shifting your perspectives so that you can align your message with that different perspective. And then you can take action. So, um, I can think of how, you would first have to understand your own cultural assumptions, even as a healthcare provider or as a member of the majority culture, or in this country. Then you have to see their different perspectives, recognize those different perspectives. After you recognize your own, then aligning your message, whatever that is, as far as patient outcomes, to that different perspective. And then all this is preparation, and then you deliver the message. And let me just remind you as I finish that you can only think about and do one thing at a time. And I am the worst, but we really can only think about and do one thing at a time. And we are so often harried and think we're doing 5 things at once, and I can't think of anything that would be more disruptive to patient care, or to what I do. Give your patients your full attention. That is extremely important. Thank you.